Hi there, my name is Crystal Sanders, and I will be discussing neuroendocrine carcinoma. I will be focusing on gastrointestinal neuroendocrine carcinoid tumors that originate in the small intestine with hepatic secondaries. So, we all have neuroendocrine cells in our bodies, and neuroendocrine carcinoma is a rare form of cancer that actually happens because of our neuroendocrine cells whenever they begin to mutate and excessively grow for whatever reason. This usually occurs in our GI tract, lungs, or pancreas, but there have been known instances that occurred in the appendix, thymus, gonads, skin, brain, and bones. And for people who are diagnosed with this type of cancer, they're usually very fortunate because it is a slow growing cancer and it can take many years to develop. So, in one case, a 2.5 centimeter tumor on the liver actually took 3 years to even grow to a 5 centimeter tumor. So, neuroendocrine tumors, or NETs, the cause of this is still under research, but there are two current theories that one, it's an inherited occurrence, or it's a mutation in our oncogenes and tumor suppressor genes, more specifically the MEN1 and NF1 genes. So, the cells that neuroendocrine tumors can affect are really the neuroendocrine cells of the endocrine system. So you have your pituitary glands, pineal, parathyroid, thyroid, and adrenal glands, and then your pancreatic islet cells and your ovaries or testicles. And then also, NETs can affect where the tumor is at directly, the cells there. So if the tumor is in the liver, then the hepatic cells can be affected and their function can decrease. NETs can also affect the tissues of wherever they're located. So for this instant, in the small intestine, NETs will usually affect all four layers, including the serosa, submucosa, muscularis, and mucosa. But because most tumors in the small intestine lack good nutrition supply, they rarely make it past the muscularis layer of the tissue. And due to the lack of nutrition and vascularity in the tumor's cell, they usually try to migrate to a place of higher vascularity, such as the liver, where all that good nutrition and blood supply and oxygen are coming through to really filter out. So the liver is actually a really good place for a tumor to latch on and have support to grow. And in a lot of cases, they're noticing where in the small intestine, due to the lack of vascularity, they're actually dying off without that good nutrition and being flushed out naturally. So it's really kind of an awesome thing about this cancer is that in 20% of cases, you have a chance that your GI tract tumor is going to flush out naturally. So I think that's just awesome. NETs can also affect the organs of our body, mostly in the GI tract, our small intestine, large intestine, colon, liver, pancreas, lungs, stomach, and there have been a few cases reported in the brain and bones. NETs can affect our organ systems, digestive, cardiovascular, respiratory, endocrine, and you'll see in the upcoming slides when I talk about the signs and symptoms of this cancer as to why these organ systems are the ones affected. So the signs and symptoms of this cancer are actually really general, and it can really cause a delay in care for a while because a lot of times when doctors hear some of these signs and symptoms, they think, oh, they have irritable bowel syndrome, ulcerative colitis, Crohn's disease. There's all kinds of ones. So for a long period of time, a lot of people are misdiagnosed for an average of 5 to 7 years. So with hyper and hypoglycemia, diarrhea, weight loss, weight gain. You have a pain in the right upper quadrant of your abdomen, usually with a hepatic tumor. Loss of appetite, GERD, skin rash. Thickening or lump to a specific part of body, I feel is more kind of centered towards the tumor. So usually at that point, they really kind of figure out what's going on. And even with jaundice, because it's usually liver failure due to the tumor kind of taking up a lot of the hepatic cells' function. You can have a change in bowel and bladder habits, bleeding or discharge from the rectum, and headache and anxiety. That really has to do because of the endocrine system being messed with, but that is so vague, and I can really understand why there's misdiagnosis for so many years. But as neuroendocrine carcinoma is becoming more known, I really feel like more and more cases are being diagnosed with it every year. The signs and symptoms that a patient will occur during neuroendocrine carcinoma really depend on the location of the tumors, number of the tumors present, and if these tumors secrete hormones, because not all of them do. But when they do, a carcinoid syndrome tends to happen, and this really occurs because the tumor has the ability to secrete hormones directly into the bloodstream. And this can really cause hyper and hypoglycemia, flushing, night sweats, severe hypertension, palpitations, and diarrhea. So whenever the surgeon is in there trying to remove the tumor, there's a possibility that while manipulating it, it can release a flood of hormones into the bloodstream, causing severe hypertension, and the patient could ultimately have a stroke or even cause death. So it's really important for the doctor to be very, very careful during surgery while manipulating this tumor out, and it really raises the risk of surgery. So carcinoid syndrome isn't fun, but with certain therapies that I'll talk about going up can really minimize the symptoms of this syndrome. Unfortunately, there is no known prevention for this form of cancer yet, due to the tumor's complexity and that the tumors do happen due to our own neuroendocrine cells. So curative surgery is really most doctors that I've talked to, because my dad had this cancer, is their number one treatment option. They want to go in and they want to get rid of all the tumors they can. Now, if they do remove all the tumors, but one of the lymph nodes that they test surrounding the tumor comes back positive, they will not consider you cured. They will only consider you in remission. But curative surgery really is the number one form of treatment. And then there's also octreotide. And octreotide is really specific to neuroendocrine carcinoma due to the fact that it binds to the receptors on this tumor specifically. And it causes the tumor to suppress growth, and it also sometimes shrinks it. So a lot of times when doctors hear that, okay, this is what the diagnosis is, they will start the patient on IM injections of octreotide monthly. Sometimes I've heard of every 2 weeks even. And that is to really stop the growth of the tumors and any new tumors from arising, and then hopefully shrink some of them for surgery. Because if some of them are too large for surgery, then they really need time to shrink so that they can remove it. Some other options are intra-arterial therapy, TACE, drug-eluting beads, and yttrium-90 microspheres. And that's really just dependent on your tumors and whether or not the doctor feels comfortable administering them. So the short-term consequences of neuroendocrine carcinoma is, of course, surgery, having all those risks, and then recovering from it. Chemotherapy is toxic to our bodies. Nausea, weight loss, vomiting, hair loss, those are all pretty much short-term. Numerous scans and procedures, you will go through a ton. Just MRIs, MREs, octreotide scans, CTs, X-rays, the whole works. And there's also a procedure they do for people who are going in to have part of their liver removed with the tumor. It's called embolization, and they actually go in and they glue off one of the hepatic veins to whichever side of the liver. So say your tumor is just consumed your right lobe of your liver. They will go in and they will embolize the right side of the liver. And they will, it really just blocks off all the nutrition and the vascularity of that liver. And it takes all the nutrition and oxygen and blood to the left side. And it's really telling the left side of the liver, hey, I'm on my own now. I am not going to have the right side of the liver. I have to be independent and grow. And it's really training that left lobe of the liver to grow and become the new liver. So my dad actually had this done, and they did it a month prior to his surgery date. And when they did it, it really killed off the right side of the liver that the tumor was in, and then his left side, instead of being left with 30% of a liver after surgery, he was actually left with 45%. So it was really great, and now his left lobe is his whole liver, and it's working great. He just has one hepatic vein instead of two. So it's a really great procedure for people who have liver cancer, and it's localized to one side of the liver. And that's another big thing as to why it's so important to be diagnosed earlier on in this rare cancer. So anyways, those procedures and scans take a lot of time away from work, school, family, etc. And all of this very quickly becomes costly in all the medical bills. Long-term consequences of this cancer, continuous monitoring like with most cancers. They like to start you out coming every 3 to 6 months. They do a 24-hour urine collection, and that is to detect 5-HIAA. And that really tells the doctor, because it is so specific to neuroendocrine carcinoma, whether or not the raised levels of 5-HIAA tells that there's cancer going on in the body, another net. So usually they like to do it every 6 months, and once time goes on, they'll probably only do it every year. It's the same with blood work to detect high levels of cancer antigens, and they're going to do numerous scans. One specifically is the octreotide scan, which is really awesome because they inject you with octreotide and you do a scan. And then you come back a few days later and you're injected with octreotide again and scanned again. And it just makes you glow like a glowworm wherever neuroendocrine tumors are. And it's really cool. So when my dad had it done, his liver just, it lit up. So when he had the scan, he also had a spot on his small intestine, and that really told the surgeon during surgery, okay, I need to scope the bowel, I need to scope all that area and try to find that other net that's glowing on the scan. So it's really cool after surgery as well, during the rest of your life, because then it can tell the doctor whether or not any nets are present. Prognosis, as far as long-term goes, it's really dependent on so many things, but I put in an example that really related to my dad, and that was a GI tumor with distant metastasis that is well differentiated, has a median 5-year survival rate of 56 months, meaning patients with this kind of cancer have a 50% chance of living longer than 56 months. So a well differentiated tumor really has a much better prognosis than poorly differentiated. And the 5-year survival rate for well differentiated grade 1 and grade 2 nets is 35%. These are just some of my references that I use throughout the process of doing my papers and presenting this PowerPoint. And I also use Dr. Zendejas a lot before all this, just for the purposes of learning about this cancer, due to my dad being diagnosed with it last year. He's doing very well, and they said his prognosis is looking wonderful. So I hope you learned something from this. I learned a lot, and I think neuroendocrine carcinoma is very interesting. And I really think it puts the word out there that just because you're diagnosed with irritable bowel syndrome or ulcerative colitis or whatever does not mean that that's exactly what it is. And I really hope that people can become an advocate for themselves and for their loved ones' health, and to really ask questions and really dig deep and try to learn more about what you're going through, because you never know. It took my dad 7 years to be diagnosed with this, so I really hope people take something from this and learn to be an advocate. So thank you for watching.